what is new in the early HER2-positive breast cancer, and are we able to cure all HER2-positive breast cancer patients? And I hope that we are reaching that point with the new data. So how we treat those patients today? When we speak about small tumors, which are tumors less than 2 centimeters size, node negative, those early HER2-positive breast cancer could be initially operated. And those patients after are going to be treated with chemotherapy along with monoclonal antibody, which is trastuzumab or Herceptin. If it turns out that the patient was not very well staged at the beginning, and at the surgery we are going to have the node positivity, then that patient is the candidate for the dual blockade along with the backbone of chemotherapy, which is sequential chemotherapy, anthracyclines and taxanes. And those data are coming from the Affinity trial that actually in the longer-term follow-up, which is 8.4 years, we saw really expressive and really impressive results regarding node-positive patients, that the invasive disease-free survival in node-positive, there is a substantial difference of about 5%. Delta is 4.9. All other patients with early HER2-positive breast cancer are going to be candidates for the neoadjuvant treatment. And that standard in care has been introduced with the NeoSphera trial. So all other patients are going to receive in the neoadjuvant treatment, which is about 8 cycles of the sequential chemotherapy, anthracyclines and taxanes, plus dual blockade. And nowadays, based on the pathological response, which could be either pathological complete response or residual tumor burden, we can further escalate treatment based on the results that we got from the Catherine trial. Namely, Catherine trial actually randomized patients who had residual tumor burden after neoadjuvant treatment to continue with trastuzumab or to switch on the T-DM1. And the longer follow-up of the Catherine trial have shown there is substantial benefit in the invasive disease-free survival in the arm that had been treated with T-DM1, which actually was 11.3%. With comparable toxicity among the arms and a little bit more higher percentage of the thrombocytopenia in the T-DM1 arm. And of course, the patients who are hormone receptor positive are allowed to continue or to start with the hormonal therapy as well. We have also Extenet trial that actually are showing us that adding neratinib after 1 year of completion of trastuzumab is beneficial for hormone receptor positive, HER2 positive breast cancer patients.